And are there any specific techniques or tools that you found useful for improving understanding and adherence during complex multi-modality treatment courses?
It's a good question. Um, Long gone are the days where patients just show up and listen to the doctor and just do whatever the doctor says. I honestly am very appreciative of my patients. We're in the 21st century now. Information is prevalent. It is okay to be informed. It is okay to ask questions. It is okay to do your own research. That research must be taken with a grain of salt because not everything that you read on the internet is accurate. And I wish that we could purport to say we could do differing treatments that don't have the same placebo controlled, evidence based medicine that has less side effects. I'd be first on the block to use those, but I have to rely on evidence based medicine based couched in good science and has been shown to have a benefit. And so when I approach patients when they have questions about differing strategies and things like that, being able to say, this is what I know and this is what the literature shows and I know and I can prove it. And we have hundreds, if not thousands of patients on some of these studies and can be able to show with very fine granularity to the best of my ability how outcomes go for those patients.
And at what point in the trajectory do you like to introduce the conversation about survivorship and survivorship planning? Do you communicate that alongside active treatment discussions? How does that normally go?
So, patients, depending on the type of treatment that they've had, are potentially at higher risk of other conditions outside of cancer that should be taken into consideration. Patients on endocrine therapy should be working with their primary care provider, making sure that their blood pressure is under control, they don't develop diabetes, that their cholesterol is under reasonable control. Those are risk factors that we can look for and mitigate to the best of our abilities. In my older patients, who are on aromatase inhibitors, something that I watch very closely is their bone health because bone density, uh, osteopenia, or osteoporosis is not something that one can feel. And so oftentimes the first sign of osteoporosis is a compression fracture or a fracture of a bone that shouldn't have broken from, routine, a fall that's our bones are only as strong as they can be. And so at some, if you're in a car accident, that those bones can break, but looking and monitoring and addressing things like osteoporosis before it reaches that point to mitigate our risks as much as possible is important. But survivorship should be, it's a collaborative effort and it's about focusing not only on the breast cancer, but the patient as a whole.
Mm. And now I want to talk about something that we don't often hear about, but we know life goes on during breast cancer, before breast cancer, after breast cancer. And there's pregnancy associated breast cancer, which people don't often address, but very much exists. So, can you define pregnancy associated breast cancer in your practice? And what kinds of presentations should clinicians keep in mind during pregnancy and the postpartum period?
So, pregnancy associated breast cancer is any breast cancer diagnosed during pregnancy and up to a year of the in the postpartum stage. Um, we have limitations on, mammograms are not recommended routinely when women are pregnant due to risk of radiation exposure. And so, over 80% of the time, breast cancers that occur during pregnancy are felt as a palpable mass. And um, the bodies are going through changes, obviously, as you go through pregnancy. And so, you're unfamiliar with as breasts grow as a result of hormone changes during pregnancy. So women particularly need to be attuned to that and monitoring and making sure that these masses are noted earlier and can be assessed safely with screening modalities like ultrasounds that can be used to detect things and can be safely biopsied with needles. But it is an uncommon um, characteristic in women. It's rare, but when you look at women under the age of 35, over 15% of patients that have breast cancer are diagnosed with pregnancy associated. So higher in those younger patients. So they definitely need to be conscientious in monitoring for that.
And which imaging and biopsy approaches do you consider most appropriate and safe when evaluating breast symptoms in a pregnant patient? And are there any that patients should be advocating for themselves, particularly?
What I'd say is every patient is different, and this approach should be done in a multidisciplinary fashion with the medical oncologist, with the surgeons, and also with the maternal fetal medicine specialists. It really takes a team to figure out timing and safety for all of these interventions. So, ultrasounds are non invasive, do not have any radiation exposure. Um, but many of the other options that we have are limited in pregnancy. Um, you can do mammograms with abdominal x ray shielding to help decrease the radiation exposure below what is concerning for exposure for fetus. Um, if there are concerns like back pain, you can do an MRI of the spine without contrast. This is not something that needs to be done for every single patient, but if you have symptoms and you're worried about, can be done with minimal exposure to baby. And then also, you can do a right upper quadrant ultrasound to look with best abilities to look in the liver to make sure that there's no areas there. But each of these are possible, but needs to be done in a multidisciplinary fashion and individualized to patient.